when they ask me, why is that you have so many presentations? I said, well, maybe we save money on travel expenses for speakers if I invite myself many times. The truth is that I had invited Professor Ranieri to give a talk, which is the worldwide expert on the extracorporeal CO2 removal, but at the last minute he couldn't make it, so I had to arrange. And basically, I'm speaking about extracorporeal organ support, showing that when you are dealing with a complex patient with more than 3 organs failing or sepsis, at that point, you have to apply all possible techniques in order to fight this enormous level of severity score. Of course, we have to let our administrators know that this will imply a larger amount of money spent for every patient. So I finished my talk of evolution before when I showed that you can support multiple organs with extracorporeal therapies, and I would focus now a little bit more on ultrafiltration for heart failure. The interesting thing is that most patients are admitted with congestive heart failure. They are volume overload, and this is the ADAIR registry that they show how much dyspnea, pulmonary congestion, rail, and dyspnea at rest and peripheral edema are representative of this kind of patient. And in this graphical description of the congested patient, you see how much different organs are actually involved when fluid overload and congestion is occurring in a patient. So over 90% of all hospitalization for acutely decompensated heart failure are due to fluid overload, and the majority of these patients have failed treatment with oral diuretics. One of the things is, what are the outcomes in patients hospitalized for heart failure? Well, as you can see here, there is a tendency to a high readmission rate within 30 days or 6 months. And there is a tendency also to increase mortality over time. One of the interesting things is that when congestive heart failure is associated with renal dysfunction or kidney disease, you have an increased hazard ratio and the risk for mortality increase significantly. 15% for every 0.5 milligram per deciliter in creatinine and 7% for every 10 milliliters per minute decrease in eGFR. As you know, when you have a failing heart, you have 2 main aspects related to hemodynamics. One is the so-called arterial underfilling, the other is venous congestion. In one case, you have the activation of neurohormonal response. In the other case, you have an ineffective natriuretic peptide system and vasodilatation. In both cases, vasoconstriction and increased venous pressure, the final common pathway is decreased perfusion pressure that starts with a functional condition in principle, but then may evolve into parenchymal damage. And of course, if you have an increased susceptibility in a kidney, this also goes in parallel with progression of chronic kidney disease. The activation of the neurohormonal system consists in increase in natriuretic peptides, renin-angiotensin-aldosterone system, sympathetic nervous system, and vasopressin, and the common base for this is congestion. As you know, central venous pressure may not be a reliable marker. Nevertheless, increase in central venous pressure is associated with a significant increase in mortality. And when you measure BNP, BNP is a marker on how much you have a dysfunction in myocardium and how much wet you may be. But when you have an increase in serum creatinine, the combination of BNP and creatinine increase practically characterize a significant decrease in cumulative survival of patients. And there is a combined effect of worsening renal function and congestion that has been clearly demonstrated in this paper by Metra and co-worker. This is an important burden for the healthcare system with an increase in expenditure that show how much hospital admission for heart failure actually is probably the key issue in this patient. And I can tell you that most of these patients are admitted to the hospital with a given body weight, and they leave the hospital with resolution of symptoms, but the body weight doesn't change too much. It means that the reason why patients are readmitted is that we do a kind of limited effect therapy in reducing just the symptoms, and we do not tackle the real problem of fluid overload over time. We have proposed to use 5 basic parameters that we call important, let's say, for managing low cardiac output state, which is heart rate, preload, afterload, contractility, and surgical result. Of course, you can consider assist device. The management of congestion may consist in diuretics at the beginning, and you have to test whether the patient is responsive or not. But in some cases, diuretics may be dangerous. They may cause an overproduction of urine, and if adequate urine is not achieved, you have to consider, of course, extracorporeal fluid removal. This is a major problem, and physicians, they think they can deal with it, but they are not able to do it, or they don't know how to do it. One of the issues is that everything starts at home with compliance to therapy, with restriction of sodium and water intake, but it ends up in the hospital. And at that point, our task is to reduce total body water and sodium store, use drugs, and possibly extracorporeal therapies, or PD in some cases. As you can see here, this paper from Gottlieb showed that using furosemide in some cases may actually lead to high production of urine. Nevertheless, GFR may be impaired by the use of furosemide. And what happened is that a high proportion of patients reduce GFR exactly in the first 3 days when the higher dose of diuretics is actually administered to the patient. That's why new modalities of fluid removal have been proposed. This ultrafiltration system called aquapheresis, where the concept of a new machine removing water was discovered by cardiologists something like 30 years after we nephrologists have been doing this with the simple ultrafiltration circuit, of course. But it's better late than never, of course. The circuit is very simple. It's simply an arteriovenous line on a venous system with an ultrafilter and what we call a SCAF circuit. Now, one of the important things is, what is the target? We should not only target the resolution of signs and symptoms. We should restore fluid status, possibly diuretic response, and avoid complication through accurate monitoring. So our techniques are ultrafiltration, but also hemofiltration, hemodialysis, hemodiafiltration, and can be used isolated, intermittently, daily, or continuous. And I would like to show you that response to fluid withdrawal may depend on several factors, depending on how much fluid you remove, how fast you remove fluid, what is the refilling capability of your circulation, what is the overall hydration status, the cardiovascular function, the tonicity of the fluid removal, and also potential errors. Let me make you an example. If you remove 2 liters in ultrafiltration with the sodium in plasma of 140, you remove 2 kilos and 280 millimoles of sodium. But if you do hemofiltration and you remove 10 liters with sodium 140 and you replace 8 liters with sodium 130, you have removed 2 kilos, but then you remove 360 millimole of sodium. So hemofiltration is the only way in which you can dissociate sodium and water removal. Also, in intermittent hemodialysis, because of the high diffusive component, you may actually have an ultrafiltration which is hypertonic compared to what remains in plasma water, which stays hypotonic. At that point, you may have intracellular flux into the cell from outside of water and cell swelling. This is not occurring with hemofiltration and ultrafiltration, where you have a kind of isotonic fluid removal. In some patients, this has been proven to be beneficial. The UNLOAD trial from Maria Rosa Costanzo, that was supposed actually to give this talk and couldn't make it, has shown that ultrafiltration was superior to standard of care. There are other studies in which the results were controversial. However, the so-called CRRT trial, in which the goal was to compare ultrafiltration with step pharmacological care algorithm on renal function and weight loss in patients, showed no difference. And if anything, it showed a slight creatinine increase by ultrafiltration. But this is the worst study and trial ever performed in the history of medicine. The design was horrible, and the way it was performed was horrible. How would you randomize to ultrafiltration a patient that is responsive to diuretic? In clinical practice, this doesn't mean anything. So it may be statistically okay, but clinically is totally meaningless. Also, the rate of hypotension they had during treatment was very high, and the same amount of fluid loss was planned in patients with 40 kilos and 120 kilos. Classically, people that had no idea on how to perform ultrafiltration were recruited to do this trial. Anyway, we need consensus, and we have done some specific meetings promoted by ADKI on this issue. And the interesting thing is that we have proposed, and Ming Chawla is the first author of this paper, to divide actually our failure in a little bit more of the classic New York classes, because there might be classes in which, for example, 3, that could be non-responsive to ultrafiltration or responsive to ultrafiltration, in which daily life is relieved by renal replacement therapy ultrafiltration to a New York class level 2. So if this patient goes back to class 2, actually is different from this patient that cannot be relieved by ultrafiltration to a class 2 level. How much and how fast to remove? How much fluid can or should be safely removed per day or per session? What are the limits? Well, we have a magic window. We know that if patients are kept in too liberal fluid intake and positive balance, they may stay in the acute decompensation area. And you know that if you ultrafilter too much or you diuretic too much, you may have volume depletion, arterial underfilling, and renal dysfunction. Now, this is what happened in normal condition. And if you have a diseased heart, this curve, U-shaped, is actually narrow and narrow. So your therapy should not go in any of these two directions, should possibly go in this direction. To do this, we have proposed the approach called 5B, balance biomarker, BIVA, blood pressure, and blood volume. First of all, balance. It's extremely uncommon to find a very good fluid balance performed in a patient with hospitalization for heart failure. Maybe you have a different experience, but we have seen many times patients in which the hydration space, the different space distribution, and the osmolarity of patient is not taken care. Patient in the ICU may be overloaded, but general balance should be achieved in the attempt to optimize cardiac output, mean arterial pressure, lung function, and tissue perfusion. So many of these patients have actually a lot of daily fluid input. Sometimes you find a patient with a line in and a saline going down, and you ask, what is this saline for? Oh, to keep the access open. So this is in an acute decompensated heart failure patient on fluid overload. So the problem is actually your balance should be considered, the day in and out should be well monitored, and also consider what are the clinical circumstances. We have seen today the do-re-mi-fa results. Patient on AKI or developing AKI may actually increase positive fluid balance in 24 hours. This is important to know. Why is it so important to have fluid balance and so difficult? Because the components may be different and sometimes people don't understand. But you must assume that you have infusion, diuretics, and extracorporeal ultrafiltration has different components that should be taken into account. However, you may go from negligible errors to catastrophic error. I would like to remind you that some years ago, in patients treated with continuous therapies in which the reset button was pushed several times, the error accumulated over time, and at the end, some patient died because there was no control on the effective fluid balance. And you may have positive and negative, of course, and the errors could be relative or absolute in terms. So, relevant to how much you remove in the unit of time or how much you remove in total. We were able to convince the companies actually to make an action in order to avoid that reset button can be pushed forever, and this now in this machine can only be done 10 times with a maximum error of 20 to 25 milliliters. You get a maximum error of 250 cc in an adult patient. Still, in a pediatric patient, this can be a problem. So patient balance is crucial. You have to use fluid with caution, consider kidney function, use diuretics and individualized modality. You might be required to remove fluid by ultrafiltration, and treatment with extracorporeal techniques should be timely instituted and accurately performed. Techniques are not all the same. How to use biomarker? Look at this case. The patient is coming with a very high BNP and very low diuresis. You start diuretics here, and you increase diuresis. Your wet component of BNP goes down, but creatinine goes up. In some cases, if you use, as in this case we did with the NGAL, you can do the same thing, but at a certain point you get an NGAL warning or a tubular marker warning, and at that point you stop the diuresis, you may reconsider your therapy, and actually what happened is that creatinine increase is not necessarily happening as it is. The same is true for ultrafiltration. Instead of diuresis, what you provide is ultrafiltration rate. In most of the cases, you can get an increase in serum creatinine. I should somehow urge you to study biomarkers of renal damage, and you can actually get information on what to do in the next hours, maybe stopping ultrafiltration, allowing for a refilling rate, and avoiding creatinine increase. BIVA is a bioimpedance that we use in chronic patients. Assessment of volume status is done invasively or non-invasively in critically ill patients with different modalities. We use a typical scale that is actually available today with a very easy measurement that tell us where the patient is in terms of fluid status. And when you match this with the blood pressure, you get the exact information about who is hydrated, dehydrated, and who is normotensive or hypertensive, and so on. So, for example, in a number of patients, we did study the absolute delta hydration status by ultrafiltration with systolic blood pressure, and what you see, this is a typical response. Blood pressure goes down, but not too much, and you get reduction of the overhydration state. But you may have also different arrows in different directions depending on the characteristic of the patient. Too much fluid is removed in this case, the patient becomes hypotensive. Or in other situations, you may have what we call the sympathetic dysfunction, in which there is no enough response to ultrafiltration. So in general, you have a mild increase in diuresis, you have an increase in sodium excretion, and in general, kidneys become more responsive to diuretics after ultrafiltration. You have to measure blood volume. Why? Because what you remove in your extracorporeal therapy has to come from the interstitial space into the vascular space to avoid blood volume changes. And we have monitors that allow to do that. Blood pressure, you have to monitor blood pressure in relation to blood volume variation. This patient has had 2 different sessions. In this case, 4 hours of isolated ultrafiltration, 3 liters removed. In this case, approximately 24 hours in which 3 liters were removed, no changes in blood volume, no changes in blood pressure, and in this case, hemodynamic instability is evident. Why? Because you may have hemodynamic instability generated by two situations. One, in the overhydrated patient, this can be due to the fact that blood volume changed significantly and you are removing too fast. In other cases, the patient may be actually dehydrated and you are removing too much. And at that point, these are the two conditions. This is a typical case of a patient with a cardiac transplant. He has oliguria, an assessed fluid overload of 17%, an estimated overload of 11 kilos, start with isolated ultrafiltration, and you see that blood volume changes are significant. So at that point, we decided to actually go for SCAF 8 hours a day, and you see that the blood volume changes are actually much less. You see that the patient is still severely overhydrated, but getting close to the target. Diuresis is still low, but in the subsequent day, diuresis is increasing, the patient is getting close to the level, still delta blood volume within 5%, and finally the patient is getting actually into a status of normal hydration, but probably even too much fluid was removed because diuresis also increased, and at that point you have the alpha-1 angle that shows that you probably should stop. So the 5B management includes the study of balance, the use of biomarkers, the use of bioimpedance, the use of blood volume, the monitoring of blood pressure, and probably this is the way you should go to treat this patient.